Good morning. The Senate Finance Committee will come to order Thursday, March 5th, 2020. Members, as you remember from yesterday, we had Senator Ralph's bill before Senate File 3813, and it was the state's response to COVID-19. And at the end of the committee, we laid it on the table. I think it's very important to continue this discussion today, and for the record, we do have a quorum. We're hoping to gain more of clarity from MDH on the funding needs and also the discussion, if we can, from the governor's office. We have not heard from him, so I'll be anxious to hear if you can share some of these questions and some of your discussion with the governor, commissioner. And then we'll also be hearing from the Hospital Association will be coming up. So with that, Commissioner Malcolm, if you would like to come up.
Good morning. Thank you, Madam Chair and members. Jan Malcolm, Commissioner at the Minnesota Department of Health. I'm joined by Margaret Kelly, our Deputy Commissioner and Budget Wizard. Thank you, Madam Chair, for continuing the conversation today. I certainly would want to get from you any specific questions that you have for the governor's office that I can bring back. But what I can tell you is that the numbers that we've shared with you are the same numbers that we've suggested for the governor's supplemental budget. I mentioned previously that what we have given you and what I'm going to walk you through today is our best estimate of kind of public health system needs in terms of not only MDH at the state level, but some funding for local public health, funding for the regional healthcare coalitions that you have heard about from us and from the Hospital Association, which are a critical planning interface with the healthcare delivery system, and a little bit of funding for personal protective equipment with the Department of Public Safety. The governor just late last week, it might have been even early this week, forgive me, the weeks are already running together, put out the question to all state agencies to think about, as the situation has evolved very quickly, what COVID-related issues other agencies might see or resource needs that they might see. And as I've mentioned, that is not yet a complete capture. It will be by the time the supplemental budget is pulled together. But as agencies are thinking about it, prompted by some questions from the governor and from us, they're starting to think, like the Department of Human Services, for example, what personal protective equipment needs might they have for their workforce that is out in direct care and treatment and so forth. So it is still an evolving situation in terms of the resource needs within state and local government. So, but we feel quite good about the reasoning behind the numbers that we've shared with you, Madam Chair, in terms of the MDH response.
Yep, we are working members off of this budget for response from the Department of Health.
Yep.
And
just a little bit more from the governor's perspective, though. I think he has been, really clear with us and with the whole cabinet that this is really a very, very high priority, job one even, from the standpoint of protecting the citizens of Minnesota in terms of not only their health, but so many other things we understand about the ripple effects of a major public health challenge like this. So we are putting an extraordinary amount of effort and time into trying to coordinate across the agencies to make sure everybody's working off the same assumptions. I think I mentioned that we have not yet activated the State Emergency Operations Center. We would probably be planning to do that after we see cases in Minnesota. But we've got sort of the preparatory work for that. We've stood up a joint coordination operation, which is essentially all the emergency management folks from all the agencies who are already meeting regularly, so that if and when it's time to activate the State Emergency Operations Center, we'll have really a running start on that. The governor invited me to join him for part of a conversation he had just this morning with the CEO of the Mayo Clinic, which, as you all know, is just a remarkable asset for the state and the nation. And while we have had lots of folks talking at the level of the laboratories, talking with each other, and folks on the ground in terms of regional planning down in that area, we really haven't until this morning, connected at the level of Dr. Ferrugia to say, how do we really leverage Mayo's preparedness efforts and capabilities with what we're doing, what we're trying to do, as a coordinated state. And he was very both grateful for the opportunity to talk directly to the governor and eager to be helpful and engaged. I won't share a lot of details with you, but I was really impressed to hear kind of what's in the pipeline for them in terms of their testing capability, and how that will be a major asset to our statewide efforts. And we certainly are going to need to coordinate clear information to the public about what that means in terms of who can go where for testing. And as you heard yesterday, the goal is to make testing much more widely available so that we can do not only help individual patients, which is kind of the healthcare system's focus, and we at MDH are really doing surveillance testing of the population as a whole, so we can get a sense of how the outbreak is evolving. So we're testing for slightly different reasons, but both sets of data are going to be critical: individual patient data and some of this population sampling data that we'll be doing. But I think Minnesotans are going to need clarity about, can they just go to their clinic or their hospital or their pharmacy or to regional centers, or how is this whole testing regimen really going to work, going to play out? So that's some kind of higher level coordination work that we're going to be doing with Mayo just in the coming days here. So I think that's just a whole nother layer of preparedness planning, in addition to kind of that kind of tactical, on-the-ground, region-by-region planning that we've been doing, really working with the health systems, Mayo and others, to kind of say, at a statewide level, in addition to your own individual systems or your own individual geographies, how is this all adding up to a coordinated statewide plan? So I think we're kicking it up a notch in terms of leadership level engagement in the conversations. The governor this afternoon is going to be joining Vice President Pence at 3 to talk about the supply chain situation. You are probably aware that the United States House passed an emergency supplemental bill yesterday. The Senate is expected to pass it today. So that's a very significant development, and we have work to do to try to figure out what that means for Minnesota. Our first blush is that it's disappointingly little for Minnesota compared to what we were hoping for, but that may be an incomplete picture on our part, because there's many, many parts to the bill. It looks as though the direct appropriations to MDH look to be fairly modest, but there's also provisions in the bill that have to do with the strategic national stockpile, which is where all the personal protective equipment and other supplies that we're hearing about from the healthcare system would be deployed through that strategic national stockpile. So funding for that certainly is going to benefit the state as well. There's some community clinic funding in the bill, hospital preparedness funding, state and local public health funding. So we need to add up all these pieces to see how that affects the estimates that we've given you. But I have to say the speed is impressive, and we're grateful for it. Sometimes it takes a while for the money to actually get to where it's intended to go. So we still need and are very grateful for the LACs working with us to make the existing $4.6 million in the fund, in the emergency response fund or the contingency fund, available now for funding the work that's going on right now, as well as this appropriation request, which we feel is not going to be duplicative with the federal resources, but we will continue to look closely at that. Madam Chair, are there any other specific questions for the governor's office that I can take back?
Oh, thank you for asking that. Yes, Commissioner. I have one as far as the governor's budget is released when?
Madam Chair, Margaret Kelly from the Department of Health.
Margaret Kelly.
My understanding is the budget is going to be released around March 10th.
March 10th. I guess I would, I'm just going to be blunt. It would be very nice if the governor could get all 4 leaders together to figure out a coordinated response to this. It seems like we're sitting here getting this really important information, trying to figure out what is appropriate for the state budget, your budget, hospital budget, and there's no direction. His budget doesn't come out to the 10th. That seems very, that's a whole other week. And is that good enough for you? Here we're trying to push this through, and I'm a little concerned that we have not had as much direction from the governor's office on what he's planning on doing too. This has nothing to do with politics. It's about getting our state prepared and doing the right thing. So that would be the message, to help us coordinate with him and his plans and his budget coming out. Senator Egbertson.
Thank you, Madam Chair. And Commissioner, help me a little bit here to understand. I know the money that's needed here, and I also see that in the handout we do have a statute that covers the public health response contingency account, which seems to identify how to spend the money very well and how to recoup the money if it's not spent. And that's always a concern of legislators, as you probably know, that we don't want a whole bunch of stuff laying in the corner someplace. Being an old emergency management director myself, I can tell you endless stories of federal money being spent on things and hardly ever get used. They get outdated before they're able to be used. So, but there's nothing wrong with being prepared. My question would be is, if there's an appropriation from the state and now it looks like about $8 billion what they're looking at the federal level, and you say it's not near enough, you don't think, and I can't dispute that. Do we know if this would qualify under the emergency management? I know the state of California, who I really don't like to model myself after, but nevertheless, they have an awful lot of folks that are apparently infected there, so the governor has done a governor's response there, or excuse me, a presidential disaster. That, I think, kicks in a whole different funding source. Do you know of that? And have you got the emergency management people at the table? Because they're used to setting up plans statewide. And I think you said you had them at the table. Do you know anything about that kind of funding?
Commissioner Malcolm.
Madam Chair, Senator Ingebretson, yes, they are very much at the table. And you are right that we believe that the governor's powers under Chapter 12 could apply to this situation if needed. We're always interested in making really sure that that definitions are clear in statute and that we wouldn't waste any time debating about whether this disease outbreak qualified or didn't qualify for a peacetime emergency declaration by the governor. We believe it does. And when we are very much working hand in glove with emergency management. In terms of the funding stream, I will ask Deputy Kelly to weigh in on that.
Deputy Kelly.
Madam Chair and Senator, there is funding in the state's disaster contingency account that the governor can access when, under certain conditions, when the president declares an emergency in the state or when the governor may. But those funds are for natural disasters that affect buildings. So if there's a tornado that comes through, those funds can be used to repair.
Madam Chair, follow up.
Yes,
And I understand that, and I think everybody is a little bit wondering if this would qualify. And I guess I would ask you to do your real level best to get that identified. Because if that becomes if it becomes more serious here and nationwide, which I think it is, it's really no different than a tornado or a flood. People are dying, and I don't know if it was used in the past in any other the pandemics, but really look into that, because that I think would free up some federal dollars.
Madam Chair, Senator, thank you.
Yes.
Would you like us to walk through the
We have a couple more
budget
questions
overview?
for you first, if you don't mind.
Certainly.
Please. Senator Newman.
Thank you, Madam Chair. Commissioner, you just got to help me understand a little bit in terms of the money that we're talking about. What is the sum of money that you're asking this committee to appropriate under this bill at this time?
Commissioner Malcolm.
Madam Chair, Senator Newman, the request for additional appropriations at this point, what's in front of you today with the limits that we've talked about on what's included and what's not, is we're seeking a general fund appropriation for fiscal 2020 of 20 and 21, excuse me, is $20,889,000. So $21 million is the operating number. The total response costs that we're estimating, and let me be clear about the time frame here. When we did these estimates, the time frame was March 1st through the end of February next year. So a one-year period for the public health component of the response. The entire cost we project to be $25,500,000, but we already have $4.6 million in the contingency fund, which we've gone through the mechanism to ask the LIC to allow us to spend those dollars now. So that's already in progress. So taking that 4.6 out of the total, it would be 21 million in new funding that we'd be looking for this. That's what this page
Madam Chair,
totals. Yep.
Thank you, Commissioner. And of the new money that you're asking for, and I understand the money that's already in the account, the new money that you're requesting, is the governor making that his recommendation?
Commissioner Malcolm.
Madam Chair and Senator Newman, as you know, the supplemental budget's still being assembled, but this is been submitted, and I have every indication that this will be the governor's request.
Madam
Senator
Chair.
Newman.
Commissioner, pretty straightforward question. I would like to know what the governor's position is on the $20 million. Is he recommending it, or is he not recommending it at this time?
Commissioner Malcolm.
Madam Chair and Senator, yes, these numbers are in the governor's budget, which has not been released yet. It's possible, as I mentioned earlier, he's asked other agencies to also take a look at this. So his final supplemental budget may include not only this number, but other state agency costs that are related to COVID as well. But is he in support of this 21 million? Yes, he is.
Senator Newman.
Thank you, Commissioner. I know that was a hard question, but I appreciate your answer. Then, in terms of the federal money, you had indicated that, the House has voted on it. You expect the Senate to vote on it, I think you said today, so you're hopeful. But I think you said that Minnesota's probably not going to get as much as what you were hoping we were going to get. Can you give us your best estimate as to how much money we would be getting from the feds?
Commissioner Malcolm.
Madam Chair and Senator Newman, all I can share with you is the number that was suggested to us from a member of the congressional delegation who thought it would be in the $10 million range. So but again, I don't know where that number comes from, and it could be just a portion of the bill would be 10 million for Minnesota, and additional resources that we could tap through the Strategic National Stockpile and other things would add to that total.
Senator Newman.
Madam Chair, and thank you, Commissioner. I understand it's an estimate, and that's what I've asked for, so I do understand that. In terms of whatever money we do get from the feds, whether it's 10 million or some other number, can you explain to me and just help me understand what would the money from the feds be spent on as opposed to the 20 million that you are asking for? And is any portion of the money from the feds going to be reimbursed to the state of Minnesota?
Commissioner Malcolm.
Madam Chair and Senator Newman, I think that's a real strength of the way the legislature built the contingency fund to begin with. There's clear language in there that if other sources of funding become available, they are credited back to the account. So if it does turn out that there's some duplication between the federal resources and these resources, those federal resources would be put right back into the account. What the 10 million, just assuming that 10 million as a working estimate in the federal bill, what that can be spent for, it will be quite prescriptive usually from the federal government. They may say, as they have with prior emergency preparedness funds, they give us a formula for how we're essentially a pass-through out to healthcare systems or to local public health for supporting their preparedness efforts. I can't tell you as we sit here today, again, because we don't quite know where that $10 million estimate comes from, what kinds of activities that those federal resources would be intended to fund. There is, as I mentioned, money in the bill. We understand it for community clinics, which is great because they're going to be a frontline provider for a number of people, as well as hospital preparedness, and local public health preparedness as well. I'm quite certain the activities will be overlapping to some degree, but in terms of who they are designated to go to, that will be something we're going to have to figure out.
And
Madam Chair.
members, there, you do have statute 144.4, a copy of it in front of you too, that mentions what is allowable in the contingency account. Senator Newman.
Thank you, Madam Chair. And the reason, Commissioner, I'm asking the question is because there's a number of different ways to spend this money. It may be on equipment, it may be on for staff, it might be for gowns and masks and maybe vaccine, hopefully. And I'm just trying to understand if we spend the $20 million on certain items and the $10 million on other items, it would seem to me not likely that the state would be reimbursed, even though the legislation is written that way. Can you give us any kind of guidance on that at all?
Commissioner Malcolm.
Madam Chair, Senator Newman, I'm not sure I'm fully following the question. I would invite Deputy Kelly to help me answer here. We certainly have had a good track record in the past of where we have used this contingency fund in the past has been for measles and tuberculosis and perhaps one other thing that I'm not recalling off the top of my head. But we have a good track record of tapping this fund for those purposes, ultimately getting some federal resources to work on those same issues, and then putting the money back in the contingency fund. So we've got a good track record of doing what the statute directs us to do by putting the money back. And we didn't have an issue then of it not being reimbursable back to the account because of the way it was spent. But there may be something that Deputy Kelly understands in the question that I'm not.
And Senator Newman, back to the A2 amendment that was amended onto Senate File 3813 on line 110, it does say that any amount that's not attributable to this section can be transferred back to the general fund. Is that what the question that you're trying to get to, Senator Newman?
Yes, Madam Chair. That is what I'm referring to, and I'm simply trying to understand, how this works, and it's not clear in my mind, and I apologize for that. But I'm just trying to understand how the money, both state and federal, is somehow coordinated, and there's often restrictions on federal money. I do understand that, and I just don't yet understand how the reimbursement to the state of Minnesota is going to be made. And it feels to me like it depends on what the money is going to be spent on. So I sincerely apologize that I don't understand this arena very well, and I'm just trying to get some kind of an understanding, that's all. Thank you.
Senator
Madam Chair.
Newman, you are spot on. I feel a little confused, too. A lot of moving parts, haven't got quite the information from the federal government, how this is all going to work. Yeah, I feel exactly what you're feeling. Deputy Kelly, if you could shine some light on this, please.
I will, Madam Chair, I will take a try. We will, whatever funds are put into the public health response contingency account, we will use according to subdivision 3, which lays out, oh, no, I'm not, sorry, not subdivision 3, subdivision 4. Subdivision 4 tells us what we can use the funds for. And so we will use the funds only for those purposes. To the extent the federal government appropriates us money for similar activities, we will use the federal money first, and we will let the contingency account sit there. So if there's 100% overlap and the federal dollars are sufficient, we would not tap the contingency account. It could be that the federal government says use it only for these two purposes, which may or may not be in subdivision, which likely would be in subdivision 4, but may or may not be. And so we would use the federal funds for those two purposes, and we would use the contingency account for the other purposes. If we start spending out of the contingency account before the federal money comes, and the federal money comes and it's for all the same purposes and there is alignment, we would stop spending the contingency account and we would start spending the federal funds. And if at the end of the day there's sufficient money in the federal grant to reimburse the contingent account, we would do that. So if there is alignment between what the feds authorize us to spend their dollars on and what we need to spend and you've appropriated money for, we would use the federal dollars first and we would reimburse the state for any expenditures we've made against state dollars with federal dollars.
Good. All right, Senator Nelson.
Thank you, Madam Chair. You know, the unusual occurrence here where we've seen our elected officials in Congress act so swiftly and it's seemingly with one voice regarding this is what we need to do it now, and we need to get this out to our states. That should not be lost on us. That is almost, we just can't remember a time where that happened. And to me, that speaks to, so we talked about the swiftness of this unified voice saying we need to prepare. And we need to get resources to the people that are going to do the preparing. And the fact that we are seeing this swiftness just is another real picture of the fact that this is spreading quickly. And while we do not want to pander and panic, the best way to not do that is to be prepared. So I am saluting our colleagues in the federal government for acting upon this swiftly without partisan sniping, which all too often happens in halls there and here. So I think that should not be lost on us, and I'm glad to see that. I also want to second Senator Rosen's concern and request that the governor and our state leaders here also meet quickly and determine a unified voice with speedy resolution what we need to do here in Minnesota. So I think this is important. I don't want this moment to be lost or delayed. And I also bring you greetings from Olmsted County Public Health. I spoke with Mr. Briggs this morning, Olmsted County Public Health Director. He sends his greetings, as do I, knowing and thankful that we live in a state that does have a robust, strong public health. And I want you to know that he stands, Olmsted County stands ready to help in any way that it can. And he also mentioned a couple things that I think are also important for us to keep in mind as well, that and that has to do with even greater communication with those counties in how they can help. They want to collaborate. I can speak for Olmsted County. They want to collaborate with the Minnesota Department of Health in being in the forefront of preparedness and containment of COVID-19. And so I offer that and ask that you continue that good outreach. And I do commend you for those calls that you're already doing with the schools, the hospital associations, and the counties. But I do believe that swift action on our part, unified action, and then terrific communication will go a long way to better prepare and also to prevent those who would choose to pander and panic. So just my comments
Chair?
there.
Thank you, Senator Nelson. Senator Kiffmeyer? And then we're going to have Commissioner Malcolm, after Senator Hayden's question two, go through briefly your request, and then we'll have the Hospital Association up. Thank you.
Thank you, Madam Chair. I would say that we tend to try and get our hands wrapped around this. And Commissioner, I really appreciate the PowerPoint slides that gives us some basic scientific information about this unique virus, how it acts, how it functions, and where it goes. And I really appreciate that, especially from the credible source. It's very important. But I was thinking more along the lines of we keep trying to think what might be the total amount. But it seems that in the preparation phase, we don't want to wait until we have an actual case. We want to be prepared for them. And so, Commissioner, if we did a portion of money earlier up front to at least really work on that preparation phase, gearing up, doing all of that, anticipating that, could we not follow up later with having the follow-up money? We're going to be in session for another 2 months, and so we have a continued opportunity to come up with that as we see things develop. So would you just comment to that kind of idea of startup and then to follow?
Commissioner Malcolm.
Madam Chair and Senator Kiffmeyer, thank you. Yes, that's precisely why we've asked to access the existing balance in the contingency fund right now, so that we can continue the preparedness. And now we're really moving from preparedness into response, even though we don't have cases yet in Minnesota, at least not that have yet been detected and confirmed. We believe that based on everything that many of you have already said, that just what's happening globally and in the United States, that we need, it's no longer a let's prepare in case this happens. It's let's take our level of preparedness into the next stage of operationalizing response. So we've been working hard on this, and as you heard from Dr. Karani the other day, emergency preparedness is just an absolute daily function of what we do in public health and in healthcare. We've got emergency preparedness plans. We exercise them periodically. Amending those plans, adjusting them, tailoring them for what we know about COVID has been something that we've been working on for about the last 6 weeks since this has really manifested as a public health threat of concern. So yes, absolutely, we've been increasing our planning efforts toward response for the last 6 weeks. We now need to take it to the next level. We've been communicating a lot. Senator Nelson rightly, reminds us that local public health is the front line here. I mean, clinicians, the folks who are seeing patients, but local public health is really who's convening those conversations at the local level with our support and partnership. So a lot of folks have been expending a lot of time and resources on this already. Now to take it into the next phase of being able to ramp up testing capability, to ramp up epidemiologic investigations and consultation with the locals and with providers is what's going to take the next level of resources, and why we feel we do need to access some of this money now. We would appreciate the appropriation of some additional funds beyond the 4.6 now, so that as this ramps up, and we don't know how fast it could materialize, that we're in a position to be able to deploy resources really quickly without having to come back to the legislature while we're in kind of the full-blown operational mode of trying to contain the disease. But your point about can we do this in stages, certainly we could. I think there is some value in having our best estimate of what we think we might need over the course of a year available to us without having to keep coming back for the next increment. But that I appreciate your point, and certainly that's something we can discuss.
Thank you, Commissioner. That is very helpful.
Senator Kickmeyer. Thank you. Senator Hayden.
Well, thank you, Madam Chair. I think that I just wanted to emphasize, I know that there were some questions about coordination at the legislative leadership level with the governor. So I do want to say that I've been to a couple of those meetings along with Senator Gazelka and the Speaker. I think Senator Benson, the Senator Ralph was at a meeting. So there has been, I just want to emphasize, because there has been those high-level meetings with the commissioner and her staff. I think we've had 3 up to this point that all of the legislative leaders, as well as the governor and the lieutenant governor, are working very closely together to ensure that this is a bipartisan effort and that we're all working really hard to ensure that Minnesotans see us working together. And so I know that I'd heard that a little bit there and wanted to really emphasize that. And then, Madam Chair and Commissioner, I just wanted to also continue, as Senator Nelson put in a plug for her local public health office, is to really put in a plug for our FQHCs. They often are they are part of the frontline effort, and they serve a very vulnerable population, usually under or not insured at all. And I worry about those folks that often English is their second language, and the communication process with them, depending upon where they live and how they receive their information. So I wanted to just put in a big plug for that set of providers as well, who often see our most vulnerable people who often don't have mainstream insurance.
Senator, Commissioner Malcolm, could you go through your list here, please?
Thank you, Madam Chair. Yes. So what's before you is the budget outline for, it's highly summarized. Of course, we haven't spelled out every activity in each of these categories. But again, the time period that this speaks to was from the beginning of March through the end of April of next year, to try to get us through a one-year period, but also timed to be sure that we have the resources we need until the legislature comes back into session and could take further action if needed next year. So again, the top line numbers, we are projecting the public health portion of this response, state health department, local health department, and some support to the healthcare coalitions and personal protective equipment for the Department of Public Safety. So that's what's included here. That was a $25.5 million estimate for the total COVID-19 public health portion of the response, minus the $4.6 million that we already have in the fund, so that we're seeking an additional appropriation of $21 million for the public health component. And the big categories of expenditure here, first, staffing, a little over $10 million, and that estimate comes from the number of full-time equivalent staff that we project are going to be working specifically on this outbreak. And I want to be really clear, this is not 100 new people. These are 100, there are a few new positions, but the vast majority, 95% of the positions are folks already in the department, epidemiologists, research scientists, communications people, planning people, who are working on other federal grants that cannot be used for this purpose. So we've got the staff. This is a matter of how we pay for the staff time that we've got. So unless the staff can be funded on this new effort, they have to stay working on the federal projects that are of far lesser priority. And we have limited authority to redirect some of that federal money, and we've already done that. That's how we've been paying for the work we've been doing over the last 6 weeks or so. The feds have said you can use, I think, I can't remember the number, I think it's 10% of your existing federal grant. You have our permission to redirect that. That's how we've been paying for this work so far. We're at the end of that. We've exhausted that federal reallocation. Thank heaven the feds are moving quickly. I certainly echo Senator Nelson's appreciation for that. It is unprecedented and so very welcome. So we now know we're going to get some more federal money. We don't know exactly how much or for what. So our estimate here is what we would need to cover the staff time that we expect to be dedicating to this outbreak. It's a lot of staff, but it's based on what we have seen in prior epidemic responses. It's kind of what we know from seasonal flu, but it's also what we learned from H1N1 as kind of the level of effort that it takes to coordinate the epidemiologic and communications and coordination functions that go with an outbreak of novel and statewide concern. The only new staffing that's envisioned in here is contracting for additional medical expertise, I believe, but we may also want to look at this in terms of some of the tailored communications that we need for working with specific populations during this outbreak. The second category of spending is for laboratory testing. Again, sort of based on testing trends that we've seen during previous outbreaks. We've made some estimates of where we start and what we ramp up to in terms of, at the peak, testing 300 samples per week. And so what that means in terms of total number of tests expected, which would be about 6,000, and the cost per sample for testing. And the assumption here is that this is just a cost that we absorb with funding, through the laboratory, rather than billing out test costs to patients or their insurers. So that's an operating assumption here. And in addition to the patient samples, we would be looking at some additional genetic sequencing to help us from an epidemiologic perspective to understand the relationship between the cases and whether the virus is evolving. So some additional samples and costs for genetic sequencing there. So that's 1.7 million, rounding up just a little bit for testing. The next category is local public health. As we've said, absolutely essential that every community health board and every Indian health agency on our native nations be equipped to beef up their staff capacity or whatever else they want to use the funding for to support their local efforts. So it's not, our intent would not be to restrict this to staffing, but it would really depend on the needs of each local health department, what it is they need. So we've made some estimates here of using staffing as sort of a proxy for resources, what the smaller health departments might need versus the larger counties and larger metro areas. So all of that adds up to 8.5 million in grants out to local public health to beef up their response efforts. We've talked about the healthcare coalitions, what a critical planning interface they are between public health and the healthcare system. So this assumes that each of the 8 coalitions will need one full-time equivalent staff working specifically on COVID. They're working on coordination all the time on a whole range of issues, but a specific COVID resource for each of the coalitions is in this budget. And the next final category, personal protective equipment. This is where we're, again, understanding the strategic national stockpile is a major resource that the feds provide, but so there will be some resource there. In the H1N1 outbreak, we purchased over 2 million N95 masks for the state for providers, including hospitals, long-term care, EMS. And we estimate that the cost of PPE for the healthcare system in what was then greater than $40 million. So that's what we'd be projecting for this epidemic, but that $40 million is not here. That's assumed to be in the Strategic National Stockpile. However, we have a need right now for some personal protective equipment for staff who are monitoring patients, doing the patient interviewing and contact tracing, as well as for some of the folks who are doing regulatory functions inside of healthcare systems, including long-term care. So the only two departments who've really thought that through to this moment have been MDH and the Department of Public Safety. So this is the personal protective equipment for our own staff that we can envision here. So that's $4.25 million. And so those categories, again, appreciating this is not a detailed breakdown, but we just tried to kind of lump it into something fairly easily digestible, and that all totals up to $21 million.
Very good. That is very helpful. Members, I think, and Commissioner, if you wouldn't mind, and Deputy Kelly, if you wouldn't mind staying there, I would like to bring up Miss Mary Krinke from the Hospital Association, and then if there's further questions, that would be great. She has the testimony here that we'd like to have. Good morning, Ms. Krinke.
Thank you, Madam Chair, and for the record, my name is Mary Krinke, and I'm with the Minnesota Hospital Association. We are very disappointed at this time that there has not been a separate allocation for the healthcare provider community, hospitals and clinics, as we're likely to provide a significant amount of care to very sick patients. And we're really not quite sure how many sick patients we will be caring for. We are hopeful that during this legislative session that additional funds will be appropriated for this purpose. I'd like to make 4 quick points, if I may. And this first one may seem a little unrelated, but it is important. The median hospital operating margin for last year was 1.7%. It has dropped from 2.3% just the year before. That is a 26% drop in operating margin for our hospitals. We have 27 hospitals in Minnesota that have negative operating margins, and most of them are in rural Minnesota. So there is no extra money that the hospitals have to do what they think needs to be done. So I just want to put that on the record. This is not a question of the hospitals being able to do right now financially what they think needs to be done. Number 2, surge capacity. There are no extra ICU beds available. There are no extra ventilators available. There's an organization in the metropolitan area called the Metro Compact. It's headed up by John Hick, who is an outstanding emergency room physician at Hennepin County Medical Center. You may recall that Dr. Hick was in charge of the bridge collapse that happened in Minneapolis. He's a fantastic physician. He heads up the Metro Compact, and every day now they are calculating the available ICU capacity in the Twin Cities. There are 521 adult ICU beds that's the capacity. On March the 2nd, there were 31 beds available. So I want to be clear that influenza right now that we are dealing with before coronavirus, most of the hospital ICU beds are full. Okay, so it's just very important to recognize where we are right now with no surge capacity. The third point that I'd like to make is that money now will make a difference. This is in both equipment purchases and staffing. So I'd like to give you just a couple examples of the equipment that is needed. So we heard from Hennepin County Medical Center that they were in need of purchasing 16 ventilators. This is their sort of quick analysis right now. If they could buy or purchase 16 ventilators, they felt that that would make a big difference. These ventilators cost $35,000. So just for Hennepin County Medical Center alone, that would be $560,000. $560,000. We've heard from Minnesota MinHealth Fairview University that they really feel they need what's called an ECMO cartridge, and I'm not a physician, but an ECMO cartridge, that is a machine, it's the extracorporeal membrane oxygenation machine. And basically what these ECMO machines do, they take the blood out of your body, they oxygenate it, they take the carbon dioxide out, and then they pump the blood back in. It basically acts as a lung for you. And obviously, they have to have cartridges for this, and they're $10,000 a piece. And the university says that they think they need some of these, they need at least 35 of these on hand to care for the very sickest patients. So at $10,000 a piece, that would be $350,000. So the next one, and this is the hardest one to get our arms around, is the building out of ICU, intensive care unit beds. So we know we have a shortage, and we're not adding to the moratorium, we're not going to add permanent hospital beds, but we need to take some of our current med-surg beds and transfer them into ICU beds. So that has some remodeling expenses, taking current med-surg beds, moving them into an ICU bed. And a number of our hospitals can do this, but it takes money up front to plan for that purpose. So those are kind of what I would call the equipment needs. And the next one is really hard for us to estimate. We are trying. This is the staffing component. So as you have more hospitalizations, you obviously need more staff. You need more staff if you have more inpatients. We're also concerned that our workforce is likely to become sick as well, either at work or just from being out in the community. So we're going to need staffing to pay for overtime and to bring in pools of other staff to cover the staffing needs. And those costs escalate because you're usually paying it time and a half or double time instead of just the standard rate. So we are looking at additional staffing costs. One of our members shared with us that they were going to probably need $500,000 to operate their phone triage system. And Commissioner Malcolm referenced this, that to keep people in the clinics, serving individuals in the clinics so they don't come to the hospital. But that takes staffing to man those type of outreach phone services so that we can keep people out of the hospitals. And so there's going to be staffing costs and equipment costs, and I believe that some money up front now will help the hospitals at least get what I would consider sort of minimum purchases made, the ventilators and these ECMO machines. My last point that I want to make is actually on accountability. I've heard from a number of the senators and representatives over the last couple days, and I understand it. They're very nervous about just appropriating a lump sum of money without knowing where that money is going or what it's being used for. And I want to make a commitment that we want to work with the Minnesota Department of Health, and if there is grant dollars that are allocated, we'll come up with some type of vendor receipt or some type of purchase order or some type of agreement so that we will show what the money is being used for, so that legislators and the taxpayers can feel like this is being accounted for. And I want to just acknowledge, I appreciate the comments that legislators are worried about just throwing a bucket of money and saying, here you go. They want to know what the money is being used for. So we'll have to work on some type of accountability mechanism. But in closing, I just want to say to everyone that preparedness has a price tag. Okay, and it costs money for the hospitals to be prepared, and they're nervous right now, guys. They're anticipating a large surge of patients, and they want to at least be as prepared as they possibly can. So we'd like to continue to work with you all. I recognize the need to get some harder numbers on what they actually think the costs are, but I at least wanted to give you a couple examples of the ventilator costs and those ECMO machines. So thank you.
Senator Westrom.
Madam Chair, my question's for the commissioner, so if there's other questions.
That's fine. No,
Okay.
that's fine.
So Commissioner, just about the lab, is this the same lab as they
they jointly use with the Department of Ag, or is that a separate lab that you're referring to?
Commissioner Malcolm.
Madam Chair, Senator Westrom, yes, it's the public health laboratory component of we have a co-located lab between health and ag, and we do some work in tandem. We can share some great learnings and so forth in that common building, but there are labs dedicated to public health and ag in the same building. So this is the public health laboratory.
Senator Nelson.
Ms. Krinke, regarding the hospitals, I would assume that our hospitals will be charging patients for the increased services that are needed. And so I understand also the fact that our hospitals have to have that expensive equipment before the patients get there, so it's ready for the patients. But I'm just wondering, as you come together and put together a more detailed fiscal request, and you've itemized very well here what many of those issues will be, and it's easy to see why those ECMO machines are costly but life-saving. But here's my question. As you bring that fiscal ledger to us, it would be most helpful if you also were able to factor in the amount of those costs that will be reimbursed through patient payment. Now, I understand, as I said, there's the sequential part of this, which is the equipment has to be there first. But it sounds like it could be some state money up front to pay for the expensive equipment, life-saving equipment that needs to be there before the patients get there. But I assume once the patients get there, that there will be hospital billings for those type of things. So that's something I would be looking for in that fiscal ledger. And then, Madam Chair, one question for the Commissioner, one comment and a question briefly. In that collaboration with the local counties, local public health, one thing that was requested that as this moves forward with people under investigation, that the local public health needs to be part of that conversation and be prepared as well. And right now, they're not, as I understand. So I think that's an important thing to get that information to the appropriate local public health. And then my question just has to do, actually it's a lingering question from yesterday, has to do with the third-party testing option now, or the third-party vendors for the testing that is an option now. And my question is, how is the supply chain affecting the advancement of more third-party providers of the COVID-19 test? In other words, there's a supply chain issue with pharmaceutical ingredients coming from China, and I'm just curious, is that affecting the ability to get more tests? I think you only have 800 now, but is that affecting that? If you could just kind of clear that up, please.
Commissioner Malcolm.
Madam Chair, let me do the second one first and then come back to Senator Nelson's point about the importance of local public health involvement. Supply chain is a major, major issue that's showing up in a whole bunch of ways, and that's just something we collectively have to get our hands around. Is every state is after the same increase in resources, and we're N95 masks as an example. You know, the available supply of N95 masks is, and I'm really going to be curious to hear more from 3M today about their view of this. This, at some point, isn't only going to be a matter of money. It's going to be a matter of availability of equipment and pharmaceuticals and the like, which is why the conversations and the planning that we have with the statewide perspective and local areas is so very important to figure out how we are going to most judiciously use what are undeniably going to be resources that are in short supply. So that collaboration is absolutely essential. In terms of the supply chain impact on the testing, it sounds to me, although I'm not an expert in this, that the test kit production of the testing, I've not heard supply chain concerns about our inability to ramp up. If there is the federal government is projecting the ability to really rapidly scale up testing capability. To be quite honest with you, we don't have all the clarity we need from the feds on how we're supposed to coordinate the testing results with private testing and what's now today coming through either the CDC or the state labs. There's a lot work going on really rapidly to try to make sure that we've got a way of communicating, coordinating, and validating all those test results. My understanding is for the private tests, they will be considered presumptively positive, but will still need to be confirmed by some combination of the state lab and or CDC. So much more to be learned, which is why kind of communicating with the public about what does it mean now that if testing becomes more widely available, what does that really mean is going to be really critical. The question on local public health, absolutely true, and actually I think I mentioned, was it just yesterday? Goodness. That since we've been doing testing in the Minnesota lab, the number of PUIs, persons under investigation, is ramping up, but gradually here. We're not being flooded with it. We've been testing since Monday morning, and every time we're testing a PUI, local public health is involved. They know very well, that we have a sample and there's a protocol when cases are announced, local public health will be right there with us.
Thank you.
So that we do very much appreciate that they're the ones on the front line of this and will be.
Commissioner, if you could ask when you're at 3M today, if there's a shelf life on that, if there's any remaining from the 2 million in 95 masks, yep. And if there's a shelf life, if we could use those. Senator Marty, question?
Thank you, Madam Chair. With the public health costs, we had a letter in our packet, item in our packet yesterday from Dakota County, and they're asking about their local health costs. They talk about quarantine costs, how public health does not have funds for alternative housing when people need an alternative to prevent exposing more family or others at home. And it could be hotel room or others. Public health doesn't have funds for this. And then if people in isolation have to stay home for a couple weeks and they don't have people able to bring in food or other food prescriptions, et cetera, that public health has an obligation to do this. And things like that, they were rewriting that to the congressional delegation, it looks from the letter. But is that included in our local public health thing in the department's request? Because that talks about staffing, and these are like other expenses. That's the first question, I guess.
Commissioner Malcolm.
Madam Chair, Senator Marty, thank you. That's a really good example of where we're hopeful that some of the federal resources, which the governors and our state state and national public health associations have been working, advocating with Congress for exactly that kind of wraparound service support. That there's no explicit funding in here for wraparound services or things like housing. However, we did say sort of the staffing numbers are kind of proxies for resources that could be used in other ways. So some of the agencies that have existing staff capacity that can redirect, their staff to work on this, but really need the resources for more community engagement or more quarantine costs or the like. Our intent would not be to be restrictive to say you can only use it for staff. But absolutely, this request is not sufficient for all of the local service needs that we would assume would be, that we would have federal support for those as well.
Ms. Greenkeep.
Yes.
Ms. Krinky.
In my comments, I focus primarily on our tertiary care centers and the needs that they have expressed to us. And I would like to make one more comment in that many of our rural hospitals will see these patients as well. And if they have what's called a negative airflow room, they will be able to treat these patients as long as they don't need these very, very sophisticated equipment. So what we're likely to see is all of our hospitals caring for some of these patients, and then there will be transportation ambulance costs. So I want to remind folks about our ambulance system being in pretty tight financial straits too. So they'll be moved then to probably the Twin Cities or Mayo. So there are costs involved for our rural hospitals, at least at this initial stage in the caring process. So I just want to be clear, it's a statewide issue, not just for our tertiary hospitals.
Senator Marty.
Madam Chair, thank you. And then separate type of issue, and it's not necessarily a health department, but it's something I guess I'm hoping the administration and we should be aware of, and that is the issue of people who are with this kind of thing. If there's in question, go check it out with a doctor. Go check if you're in this condition, go to the hospital, whatever. And as much as a third of the population has high deductible plans or no insurance, is there anything being done to figure out how we might deal with that? And then I have one comment.
Commissioner Malcolm.
Madam Chair, Senator Marty, thanks. I think that this issue of economic barriers to care is something to be considered in this whole response. And all I can really tell you is that's a topic of conversation. We don't have a proposal exactly related to what should we do for people without insurance, other than relying on the community benefit capabilities of the health systems, which is not adequate. I realize, but I think it's definitely in the planning conversation. Madam Chair, if I might, Deputy Kelly just reminded me of something important that I should clarify. When I mentioned the involvement of local public health, local public health obviously needs to know when there are cases in their jurisdiction, but for protection of patient privacy, we would probably not be intending to have the local public health director standing there with me making press announcements. So we really work quite hard to not give details out to the media about details of who or where these folks are. So I appreciate the opportunity to correct the record. Thank you.
Thank you, Commissioner.
And then,
Senator Marty.
Chair, just finally one comment, and that is that because of the nature of this thing, I'm glad that steps are being taken that are, but I hope we, as a legislature and the governor, recognize that whatever comes out of this bill this week, that we may well be looking again at the end of session, oh, we got to do this again. And as we know, special sessions, which I don't think any of us hopes, and maybe this will be it, and, oh, we were over-prepared for it, which I don't know that you can be, but that this takes care of it. But we may be back here with a far bigger scale thing
Absolutely.
2 months from now.
Absolutely. Senator Newman.
Thank you, Madam Chair. Mrs. Krinky, you are quite correct that accountability is an issue, and partly because we legislators are being asked to look into a crystal ball to make our best estimate on the basis of what folks like the commissioner are telling us. And I can tell you I'm not particularly adept at foretelling the future. In your testimony, you outlined a number of areas that you felt local hospitals and clinics were going to need money for, and you said that you need the money now, but I didn't hear a figure. Can you give us a figure now, and if not, keeping in mind that we're being pushed pretty hard to act on this, when would you be in a position to give us that number?
Ms. Krinky.
Madam Chair and Senator Newman, so our members over the weekend worked very hard at putting together some of their estimates of what they thought they would need. I'm being fairly frank here, their numbers were very high, and I think it was not necessarily knowing what all was going to be in the Department of Health's bucket. For instance, personal protective equipment, a lot of our hospitals had put in information on personal protective equipment and what they thought their needs would be. Well, now we have sort of learned that that element of personal protective equipment will probably be purchased via the health department and then be allocated to the hospitals. The commissioner's nodding. So some of this is we need to push the hospitals to do a little bit more of what I call pencil sharpening as to what exactly they think is in their bucket versus what is in the Department of Health. So I have done some sort of, and I just sort of lay this out to you all. We have 78 critical access hospitals. These are the small rural hospitals with less than 25 beds. So you could think about an amount of money that might be appropriate for a critical access hospital to address their needs. So there are 78 of those. We have 49 hospitals that are called PPS hospitals, prospective payment hospitals. These are the larger hospitals, the regional areas like Alexandria, Wilmer, Bemidji. They have more than 25 beds, and they're kind of like the larger regional centers. They will probably need additional resources. Then we have mHealth Fairview, the university, which is one of 10 in the nation designated hospitals to take care of infectious diseases. So many of these really, really complicated cases will probably go to the university. So they probably have a little higher level of need. So, you know, if I were laying this out, I would probably say something like we need one bucket of allocation potentially for our critical access hospitals. We need one bucket of money potentially for what I call these regional community hubs like the Bemidji's, Alexandria's, the Wilmers, and then one bucket for the university probably. So that's just, and you know, you can kind of scale that up or down. But I am really trying to hear the concerns that have been presented to me in the last 2 days to really push our members in terms of what do they think they need now. I don't know if that helps.
Madam Chair.
Senator Newman.
The only comment I would have is I did not hear an answer to how much, and I did not hear an answer of when. So I would simply urge you to get to your members and get back to us with how much money you are asking for. Because right now, while you have given us a very nice explanation of why you need the money, I don't know that it lies in my field of expertise at all about what you were talking about. Kind of looking at Senator Klein, maybe he understands, but we are going to need that information, and we're going to need it very quickly in order to evaluate your request. Thank you, Madam Chair.
Thank you, Senator Newman. Senator Benson.
Thank you, Madam Chair. And I just heard you say we have 1 of 10 in the nation, and we have the Mayo Clinic, which is nation leading. We are very fortunate in this state to have the healthcare systems that we have and to have one of the top public health labs. Just a couple of things that I noted as we went through this process. This MDH request, while there are specific numbers written on the page, they can be used for any of the items within this section of statute. I don't think it's our intention as a legislature to restrict that, and so they could flex some of those dollars. What I don't know is, does paragraph 10 allow for vents and ECMO? Those are some things that I think need to be clarified. As I listened to Senator Nelson's concerns about could hospitals bill back for some of these expenses, yes, they probably can, but what I don't know is can they bill back for the quarantining of staff who might have to stay overnight day after day, because once they've been in contact with a patient, going back to their families is untenable. And so I don't know the answer to that question. We learn more every day how this virus behaves in populations, and I think we're learning a great deal from Washington and now California We don't know what the federal response money will look like and what it can be used for. Is any of it going to go directly to the hospitals? I don't know if any of it's going to go directly to nursing homes. I would like some answers to those questions, and it seems that that is emerging and becoming more clear. We need the leaders. We need the governor to take a position. We need the leaders of the 4 caucuses to sit down and understand how MDH works with hospitals and long-term care, what the hospital request is going to be, what are long-term care needs going to be, how are we going to deal with assisted living facilities that only have marginal nursing capacity. We don't know that right now. As Senator Marty pointed out, we need a plan for legislative interim. Are we going to allow some contingency into the reserves if this becomes more emergent? Because the idea of a special session, if we're in the middle of a hotspot, if the Twin Cities would become that, doesn't seem like a good choice. So I think that's something that the leaders need to talk about. I would say for my part, and I hear on this committee, that we're ready to support what is necessary, but what we need is a better idea of what the structure looks like going forward. And I think Senator Kiffmeyer's approach of maybe we do this in steps. Maybe we get some money now, be clear what our direction is, and then as we go through legislative session and we get better information, we can keep apportioning out funds. So I think those are some leadership decisions that need to be clarified. I think it's important that we make the best decisions we can with the information we have in a timely manner. And so, Madam Chair, I know we had talked about 20 million for MDH. Right now, I am not clear as to, is that the next best thing? I do believe that there is some money that is needed, but your request goes through February, and we don't know what the hospitals need. And so I feel uncertain sitting at this table right now, Madam Chair.
Thank you, Senator Benson. And Commissioner Malcolm.
Madam Chair, Senator Benson, thank you. Thank you all for your commitment to working with us to get this right on behalf of Minnesotans. And I was very encouraged that the caucus leaders and the leaders of the bodies and the relevant chairs have met with the governor. I think he is very, very interested and committed in continuing to have excellent communication and coordination on these larger pieces. You're absolutely right that this is our best estimate of what we have direct line of sight to right now in terms of the needs that we are responsible for. Madam Chair, Chair Benson has been really clear with me all along that she wants to see kind of a coordinated, unified approach to this. I can certainly pledge that we're absolutely wanting to work with the healthcare delivery leadership to understand what their needs are. And like you, we're eager to get that level of detail so that we can correlate it with some of our thinking as well. So just a very sincere thank you for the questions that you're asking. They help to sharpen our focus on what you need answers to. And certainly we'll mention the idea of more of a resource coordination discussion with leadership to the governor.
Thank you, Commissioner. Ms. Creaky, did you have closing comments? Okay, thank you.
Thank you for this opportunity.
Absolutely. And more questions will be coming, but I believe we've got a good start here.
I'm going to go back and tell them about Senator Newman.
Please do. He's priceless with his questions. Greatly appreciated. I know we pushed it pretty hard, and really do appreciate you, all three of you coming, Deputy Kelly, Commissioner Malcolm, and Ms. Krinke. But I think there's still some uncertainty. We as the Senate have a few more questions. Some more work that we need to do today. I know the governor, my request, and I believe you've heard it, that we'd like to hear a consensus from the governor and the 4 leaders. I know they have met. I think the last time they met, though, on this issue together was last Friday. So this is moving very fast, and we are just not comfortable making this amendment at this time, so we're going to go into recess. Thank you.